Good morning, ladies and gentlemen. For today's CPC, we have a very interesting case. 18-year-old young person who has high-grade lymphoma and has complications because of lymphoma, which is Enterobacter. And Dr. Kushal, who is assistant professor in Department of Clinical Hematology and Oncology, will discuss the case. And I will request those, those who are attending are having flu, cough, to at least wear masks. Thank you very much.
So good morning, respected faculty, dear colleagues and my juniors. So we'll quickly run through the case. So she was an 18-year-old patient from Chamba who had presented with a history of fever for 2 months, fatigability for 2 months, lower limb swelling for 10 days, and backache for on and off for 2 months associated with tiredness. So she was apparently well till October 2022 when she developed fever up to 104 degree Fahrenheit with chills and rigors, intermittent, no diurnal variation with weight and associated with weight loss, which was undocumented, with loss of appetite and fatigue, inguinal swelling since the last 1 month, insidious onset, gradually progressive and not painful or itchy or associated with post-discharge, history of sensation of abdominal distension and abdominal pain on and off. Patient also developed both lower limb swelling, insidious in onset, progressively started from the ankles and then progressed to mid-thigh, history of redness. There is no history of redness, itching or post-discharge. And on and off backache since 2 months, localized to waist bilaterally, no radiation to lower limbs, no history of tingling and numbness. And she had also complaints of reduced sleep, and there is no history of night sweats, shortness of breath, orthopnea, PND, jaundice, constipation, loose stools. There is no history of cough, hemoptysis, hematemesis, chest pain, palpitations, syncope, headache, loss of consciousness, and seizures. So she does not have any significant past history. Her personal history was of mixed diet, normal sleep pattern initially, and normal bowel and bladder habits prior to the starting of her complaints. Family history, there is a history of malignancy in the family. It was colorectal cancer in grandmother. However, we didn't have any records. And the treatment history, the patient was admitted in a hospital in Tanda, but we don't have any records to substantiate what treatment she underwent. So on examination, her blood pressure was fairly stable, 112/76 at the time of admission. Pulse rate was 100 per minute, regular, and respiratory rate was 22 per minute. She was afebrile, and SpO2 was 97. On the general physical examination, she had pallor and edema of the bilateral lower limbs and lymph node, inguinal lymph node, which was palpable. The right-sided inguinal lymph node was not palpable, and JVP was not raised. Systemic examination, CVS systemic examination was normal. The respiratory systemic examination was also normal. There was no added sounds. Abdominal lymph nodes, the abdominal examination was soft, non-tender, no hepatosplenomegaly, bowel sounds were present. CNS, it was largely no abnormality detected. So investigations outside, it was also unremarkable. The TLC was fairly normal. HB was, hemoglobin was 9.5, platelets were 1.52 lakh, urea, creatinine and uric acid was normal, sodium potassium was 130 and 4.5, bilirubin was normal. She had low albumin, which was in the borderline range of 3.0. So USG, which was done outside, had, we don't have the record of the USG per se, but there was one comment in the file which said that, she had a left tuberovarian complex mass, query pyosalpinx. Tumor markers which were done outside were normal, AFP, beta HCG, and LDH. And for the baseline PET scan, I would like to call upon Dr. Yamini to just run through the PET CT. Dr. Yamini, please.
Good morning, everyone. So this patient underwent PET scan on 12th of December 2022 outside, and this is the MIP image showing physiological uptake in the brain and the liver. Then there is an abnormal foci of increased tracer uptake in the left supraclavicular region and the whole of the abdomen and pelvis extending into the thigh. So these are the hybrid images. Cross-sectional hybrid images showing increased FDG uptake, which localized to a left supraclavicular and level 4 cervical lymph nodes. Then there was a mildly FDG avid subcentimetric anterior diaphragmatic lymph node and paravertebral lymph node. Then there was this discrete and conglomerated lymph nodal mass in the retroperitoneum, including the para-aortic, pre-aortic, aortic cable, retro cable. And these are the ileocholic lymph nodes, which are intensely FDG avid. And going down, there was a mildly FDG avid mural thickening in the sigmoid colon with the SUV max of 3.7 and about 1.1 centimeter in thickness. Apart from the lymph node and the sigmoidal thickening, there was also mildly enhancing FDG avid soft tissue densities involving the muscles and intramuscular planes. And apart from that, there were nodularities in the subcutaneous and cutaneous thickenings along the pelvic and the thigh region. So, and these are the serosal deposits along the mesorectum, which are also FDG avid. And these are the inguinal lymph nodes on the left side and the right side, causing the edema on the left side. Then these are the cutaneous thickening in the proximal thigh left side. These are also mildly FDG avid. So these findings, that is the FDG avid lymph nodes above and below the level of the diaphragm, serosal deposits, mural thickening in the sigmoid colon, and subcutaneous cutaneous thickenings were considered to be the involvement of lymphoma. Thank you.
So thank you, Dr. Yamini. So just as a gist, the patient was admitted on 13th and expired on 25th. So we will quickly run through the lab investigations during the course of the admission, and then we will further go down to the other diagnostic investigations which helped us. So for investigations at PGI, one investigation was done outside, for which the hemoglobin was 8.8, done on the 7th of December on an OPD basis, and platelets were 74,000. Now, patient was admitted on 13th December and in the IPD, and her hemoglobin was 9.1, TLC was 8,600, and platelets were 1.85 lakh. And on 19th, it was hemoglobin had fallen down to 7.2, and TLC was 13,700. It had risen a little bit, and platelets were 1.42 lakhs, and there were giant forms on the previous CBC. On the 23rd, that is 2 days ante-mortem, so the HB was more or less stable at 7.0, and TLC was rising 16,200, and platelets had again fallen down to 78,000, and there was electrocytosis and anisocytosis. Inpatient, we also sent some tumor markers for carcinomas, which was serum CEA, which was normal, and serum CA 125, which was 95, which is borderline high. And the coming to the biochemistry panel, initially her electrolytes were normal, but later she developed hyponatremia on the 19th and 23rd. So it was grade 3 hyponatremia, which was subclinical, which was not manifest as anything clinically. Creatinine was, to begin with, it was normal. It was less than 1. However, 2 days prior to her death, her mortality, the urea had increased to 84 and creatinine had increased to 1.29. More than 25% increase in the creatinine, and bilirubin was normal throughout her stay, and AST, ALT, and the liver enzymes were normal. The albumin was going down by from 3 at the time of admission to 2.04 pre-mortem ante-mortem 2 days, and electrolytes magnesium, calcium, phosphate were fairly normal. LDH is initially high; it was around 300. And it had increased to around 530, 540 on the day of admission, that is on 13th, 12th. And we had given some treatment. After that, the LDH had fallen to around 229. Among others, the amylase was normal. We did it because she was only complaining of abdominal distension, abdominal pain. We got it done. Amylase was normal. However, CRP, there is one report of on 23rd December, which was high. Coagulation profile, the INR was normal of 1.66, a little on the higher side. D-dimer was raised. This was significant, 3,601 on the 23rd. viral markers were non-reactive. We had sent a blood culture which was reported on 29/12. Most likely it was sent post-mortem, and which had grown Enterobacter harmoniaceae, and which was a sensitive strain. And now for the cytopathology discussion, I would like to call upon Dr. Nalini ma'am to quickly run through the cytopathology. This cytopathology was done outside actually. We reviewed the smears at our place. So from the supraclavicular lymph node. Ma'am.
So good morning, everyone. In this particular case, we received 4 smears for review. And as you can see, we have this kind of dispersed population of atypical cells. And this is another part to show that there is no clustering. So dispersed population of cells means there are high chances of it being a lymphoma. And then in the background, we have these Lg bodies. So these cytoplasmic fragments, which are Lg bodies, and they tell you that this is probably of lymphoid origin. So that's the higher power, and we can see this basophilic cytoplasm. Individual cells which are round, they have round nucleus, open up chromatin, and slightly prominent nucleoli. The main important thing which was quite prominent here was basophilic cytoplasm and this kind of coarse vacuolation in these cells, and we could see some lymphoglandular bodies. So on these smears, we said that it is suggestive of non-Hodgkin's lymphoma, and a repeat FNAC was advised so that we can collect sample for ICC, immunochemistry, and flow cytometry. Thank you.
Thank you, Dr. Nalini ma'am. So, apart from getting a surgical lymph node of the biopsy of the left inguinal region, we were also simultaneously parallelly evaluating for the swelling in her legs. So we had got a ultrasound compression of the bilateral legs and the ultrasound bilateral lower limb arterial Doppler, which were normal. So the left inguinal lymph node biopsy was still awaited. ECG was normal. And to discuss further about she also underwent a CTPA. So on the 23rd. So to discuss about the CTPA, I would like to request Ma'am Nidhi ma'am to come over.
On 23rd, CT pulmonary angiography was done to rule out any pulmonary thromboembolism in view of the raised dimer levels. Similar to the previous PET CT scan, we could see enlarged conglomerate lymph nodes in the left lower cervical region, in the cardiophrenic region, as well as in the visualized upper abdomen in the gastrohepatic region. Few prominent lymph nodes were also seen in the right axilla. But no evidence of any pulmonary thromboembolism was seen. The main artery, the branches were clear with no evidence of any filling defect. But new findings of gross right pleural effusion were seen, which was causing passive collapse consolidation of the right middle and the lower lobes. Mild left pleural effusion was seen. In addition, there was diffuse fat stranding seen in the lateral and anterior chest wall with presence of fluid along the subcutaneous and the intermuscular planes. These are the lung window sections which showed collapse consolidation. However, no additional finding was seen. So these findings of lymph nodes are consistent with the diagnosis of lymphoma. And in addition, bilateral pleural effusion was seen, which will be explained further.
Thank you, Dr. Nidhi ma'am. So we had also got her 2D echo and ECG done, which was normal. So clinical discussion. So just a course during her treatment, we did the biopsy of the inguinal lymph nodes on this 16th. And from that day onwards, we started her on steroid prephase, which was based on the provisional diagnosis of high-grade NHL. And we monitored her TLS parameters. Over a period of 5 days, we gave her Visolon. And after around 7th or 8th day, her platelets had a good improvement. And however, after she never mounted a fever during her course of the hospital stay. So that is important. So after 7 to 8 days, her HB and platelets started falling again. On the day of the event, that is on 25th, she was more or less comfortable. but she suddenly collapsed during the rounds. Preceding to this, 1 day prior to this, she had recurrent episodes of hypoglycemia, which we will discuss further as part of a clinical discussion. So, summary of the case: she is an 18-year-old student with history of fever, fatigue, clinical bilateral limb swelling for 2 months, associated tiredness and backache. No fever after admission, history of weight loss, appetite loss, and lymphadenopathy, which was general. So what we have till now on our plate is relevant investigations, which was thrombocytopenia, multiple lymph nodes on both sides of diaphragm, uptake in colon and mesocolon, pelvic muscle deposits on PET, rising TLC, fall in platelets and hemoglobin after initial improvement, raised serum LDH, raised CRP, high-grade NHL on review of outside lymph node smears, renal dysfunction on day 10, day 11, raised D-dimer levels, normal Doppler and CTPA was there, normal tumor markers, which were CA 19.9, CEA, beta HCG, AFP, and CA 125. And 1 day prior, she had also had an episode of PSVT, which was reverted with adenosine. And blood cultures, sensitive strain of Enterobacter hormeri, which has grown. So issues for discussion is the primary disease, whether it was NHL or something else. And we will be talking about high-grade NHL versus leukemic infiltration and metastatic carcinomas. And the terminal events and the cause of death, and the possible cause of death. So primary disease, we have for high-grade NHL, age at presentation, B symptoms, raised LDH and CRP, lymphadenopathy and muscle deposits. Response to prephase, no abnormal blasts on PS, so that essentially may rule out leukemia. Bicytopenia, normal tumor markers for carcinoma. What we are still not able to explain is the deterioration of HB and platelet after initial improvement, and the colonic thickening, which was around 1.1 centimeter on PET scan. For leukemia, it was, again, this is the same age of presentation of leukemia also, and she had bicytopenia with borderline low normal TLC. There is a history of fever, which is infections, which is common in leukemia. Response to steroids, ALLs frequently respond to steroids. Deterioration of hemoglobin and platelet after initial improvement can happen with leukemia. And normal tumor markers for carcinoma. What we could not explain with leukemia was no abnormal blasts on peripheral smear, colonic thickening, and lymphadenopathy and muscle deposits, and no bleeding. So patients of leukemia frequently present to us with infections and bleeding. So most likely it was NHL. So differences between lymphoma and leukemia, I would not go into the details. So common treatments is for initial tissue in lymphoma is lymph nodes, spleen, liver and thymus. For leukemia, it is bone marrow and blood. So the common treatments, I will not go into the details. So associated complications in lymphoma is low blood count, hepatitis B virus reactivation, neuropathy, tumor lysis syndrome, increased risk of infections, excessive bleeding, and the 5-year survival is quite is impressive for Hodgkin's lymphoma and 72% for NHL. For leukemia, it is low blood counts, usually present with, they may have transformations from CLL, kidney dysfunction, increased risk of infections, and excessive bleeding. So the mortality rates are higher with leukemia. So this is the common presentation of lymphoma. As you can see, the symptoms are painless enlargement of lymph nodes, fatigue, night sweats, fever and chills, weight loss. So this was, all of them were present in our patient. So this is the age-specific incidence rates of NHL subtypes. So mostly NHL is a bimodal sort of a distribution, more frequently in the elderly. However, there are a few high-grade NHLs which can present in the young as well, especially Burkitt's and all. So these are the clinical and molecular subtypes of DLBCL. So when we talk about NHL, high-grade NHL, we frequently come across DLBCL. So there are genomic profiling has shown that there are clearly two types of NHL, one of which is ABC and the other is GCB type. The prognosis is poorer in ABC type. So in our patient, age less than 60, LDH was elevated, stage 3 and 4, both sides of the diaphragm was involved. External sites were more than 1, muscle deposits were there. Performance score was ECOG 3 or 4, so she had a score of 4 and poor prognosis, and estimated 4-year survival was 44% only. So for carcinoma, what we had positive findings were, colonic thickening, that could have been one possibility for carcinoma, fatigue, tiredness, lymphadenopathy and muscle deposits, no abdominal blasts on PS, bicytopenia, and deterioration of hemoglobin and platelet after initial improvement can happen with carcinoma. What we cannot explain with the diagnosis of carcinoma is that age of presentation. Carcinomas are not frequent in such a young age group. Raised LDH and CRP response to prephase and normal tumor markers for carcinoma. So this was also less likely. Now the second issue was the terminal events and the cause of death. Recurrent hypoglycemia, as I already said, just 1 day prior to the event. The sepsis. So terminal events, the another possibility was of acute massive pulmonary embolism because she collapsed suddenly. Okay, what were for the raised D dimer, poor mobility due to limb swelling, malignancy as a procoagulable state, sudden clinical deterioration, rhythm disturbances in PTE, deterioration of renal functions and hypoalbuminemia. Against, we have hard evidence against PTE was that CTPA and Doppler were normal, was receiving low molecular weight heparin prophylaxis already, hypoglycemia cannot be explained, normal cardiac function and absence of shortness of breath and normal BP till terminal event. So this was less likely. What we got post-mortem in the cultures was Enterobacter hormeici septicemia. What was positive, which we had hard evidence to prove that, it was most likely this, because of blood culture growth of Enterobacter hormeici, rising TLC after, during the course of our hospital stay, fall in platelets and hemoglobin suggestive of sepsis, raised D dimer, renal dysfunction. CRP was also raised just 2 days prior to the this thing. Although it can happen also with cancers and lymphomas, it was fairly raised, suggesting there might be some sepsis ongoing. Hypoglycemia is a sign of overwhelming sepsis. Okay, and against what we could not explain was that she never developed fever during the course of her hospital stay, but we can also say that it might be due to paracetamol effect or due to steroids. And stable blood pressures and borderline tachycardia. So this was most likely. And the other thing which we were considering is that the possibility of tropical pyomyositis. So PET scan, there were multiple deposits inside the muscle planes, and she had constitutional symptoms: raised LDH, CRP, D dimers, hypoglycemia, rising TLC, fall in platelets and hemoglobin, pretty much suggestive of sepsis. Which was against was that, again, she was afebrile presentation. She had response to steroids with improvement in platelets and HB, and blood cultures had gone an alternative organism. So with tropical pyomyositis, the most common organisms implicated are streptococcus. So this was also left less likely. So briefly about tropical pyomyositis, if sir allows. I think. So this was a paper by Dr. Sir only in 2004, in which he had published about tropical pyomyositis. I would suggest all the residents to go through this paper once. This was published way back in 2004. So pathology, suppuration with skeletal muscles manifesting as single or multiple abscesses. There might be a history of trauma. Organisms, Staphylococcus aureus, most common, about 90 to 90% complaints of comprised of streptococcus. So muscles, quadriceps, frequently pelvic and the large muscle, bulky muscles. Diagnosis on ultrasound and computer tomography.
I think you can ignore this.
Okay.
Come to the bioanalysis.
So Enterobacter, about the Enterobacter hormeici, it was a species of Enterobacter cloacae family, and it is a highly pathogenic organism in the humans. So final diagnosis: high-grade NHL, B-cell lymphoma, stage 4 BE, with Enterobacter hormeici septicemia, with renal dysfunction, with overwhelming sepsis, with cardiogenic and refractory shock. Cause of death: septicemia-related refractory shock.
Thank you, sir, and very good morning to one other. So, this patient had a antemortem biopsy from inguinal lymph node. So, here we can see this is a scanner of the lymph node which was enlarged, and with diffuse effacement of the architecture, we can't see any follicles which are normally present in the lymph node. And we can see this diffuse pathology is also extending into the adjacent fat. So there is perinodal spread. On a higher magnification, we can see this diffuse pattern of involvement, sheets of these atypical large cells. We can see a few mature looking lymphocytes in the background. So these cells are quite large. compared to them. So further higher magnification, you can see these cells. So these are for comparison. These are some of the resident mature lymphocytes which are present within the lymph node, and these cells, which are the tumor cells, are quite large, 3 to 5 times size of the mature looking lymphocytes. They have a large nuclei, 1 to 3 prominent nucleoli, and they have some amount of cytoplasm here also. You can see some of the cells have moderate cytoplasm, and there are many mitosis, including some of this atypical looking mitosis. And to appreciate the morphology of these cells, if you see again here, many of these cells have this kind of lobulated nuclei and quite atypical looking cells, this kind of nuclear indentation, and moderate amount of paleoeosinophilic to amphiphilic cytoplasm. So we kept a possibility of high-grade lymphoma, and we also performed IHC. However, while doing this, the patient demised, and partial autopsy was performed, and the patient at the time of autopsy, the prosecutors noted patient was a heavy build and serous cavities were normal. So multiple lymph nodes were sampled during the autopsy. There are these large conglomerate masses of lymph node we can see here, and some single lymph nodes, some this kind of conglomerated masses, and they were seen in multiple places. We'll show you. And the cut surface of those lymph nodes were quite firm and fleshy and homogeneous. So there were large retroperitoneal pre and para-aortic lymph nodes. You can see here, this is the bilateral kidneys, ureters, aorta, inferior vena cava, which is this aorta and inferior vena cava are actually encased by these large masses of lymph nodes here, which are all conglomerate and compressing these vessels. Large group of lymph nodes are also seen in the periportal region and peripancreatic region. So a scanner view of one of the lymph nodes masses, where you can see this again diffuse effacement of the nodal architecture. However, in some lymph nodes, you can still see in the post-mortem evaluation some residual follicles, and there is marked interfollicular and parafollicular expansion. And again, on higher magnification, you can see these atypical cells with many nuclear, with indentation of nuclei, irregular nuclear membrane, and prominent nucleoli in some. And you could also appreciate this kind of cells with convoluted nuclei, which are also known as hallmark cells. So, keeping a possibility of lymphoma, we performed a panel of IHCs. So this is CD45. We can see this, the residual reactive cells are strongly positive for CD45, whereas these tumor cells are quite weakly positive, and some are negative also. So tumor cells are weakly positive for CD45. The residual follicles are positive for CD20, but the tumor cells are negative, and same for CD3. The large tumor cells were negative. These are the reactive cells, which are the residual cells of the lymph node, were positive. EMA showed strong membranous positivity in the majority of tumor cells. They were negative for other B cells markers, pancytokeratin, SAL4, thus ruling out a carcinoma or a germ cell tumor. Other panty cell, it was negative for CD3, but we went ahead with other panty cell markers like CD2, 5, 7. 2 and 7 were negative. CD5 showed again membranous positivity in the tumor cells, so indicating this is a T cell lymphoma. CD30, very strong membranous positivity with Golgi zone accentuation in some of the tumor cells. So this was quite diffuse and strong positivity. Here again, you can see strong CD30 positivity in the tumor cells. So this is definitely the morphology and IHC panel is quite diagnostic of an anaplastic large cell lymphoma. So in anaplastic large cell lymphoma, we have to do ALK, and this case shows strong nuclear and cytoplasmic positivity for anaplastic lymphoma kinase. So this is a surrogate IC marker for that translocation. Again, another picture showing strong nuclear and cytoplasmic positivity. And also this case showed nuclear positivity for MUM1. So majority of the tumor cells showed strong nuclear MUM1 positivity. So what we are dealing with basically an ALK positive anaplastic large cell lymphoma. So briefly about ALK positive ALCL is the CD30 positive mature T cell lymphoma with aberrant expression of anaplastic lymphoma kinase protein, which is secondary to the rearrangement of ALK gene. So this is comprising of 10 to 15% of pediatric and adolescent non-Hodgkin's lymphoma. And this pattern of the commonest partner for this ALK gene rearrangement is NPM1, and so this NPM1 ALK translocation, which results in this characteristic nucleus and cytoplasmic pattern of ALK expression. So with the diagnosis of ALK positive ALCL, we'll first show you the extent of the disease. So this was abdominal skin taken from abdomen at the type of autopsy. So epidermis dermis did not show any infiltration. However, in the subcutaneous fat, we could see this infiltration by these lymphoma cells. Sampling from psoas revealed extensive heavy deposition of these lymphoma cells with destruction of these skeletal muscle cells. Pancreas, extensive infiltration within the pancreatic parenchyma, destroying the acini, entrapping the nerve, and also extending the peripancreatic fat. And the ovary, we can see this side is slightly bulky, and this side is normal looking, and there was no nodular deposit. However, on sectioning from both the ovaries showed extensive deposition by this lymphoma. This is the section from adrenal. We could see this deposit of this lymphomatous cells in the periadrenal fat. We examined multiple sections actually from adrenal, but there was no infiltration within the adrenal parenchyma. Coming to the GI, this is the esophagus stomach. There was mild congestion of the mucosa. Microscopically, there was no deposit in esophagus or stomach. Small intestine, we can see normal mucosal pattern, and microscopy reveals normal mucosa and submucosa muscle. There was no deposit. Now coming to the large intestine, this is the appendix, and this is the left colon. We can see the sigmoid and rectum. So compared to the rest of the large intestine, we can see here this is markedly thickened, and there is nodularity on the serosal aspect. And on cutting open the sigmoid and rectum, we can see here there are large polypoidal projection of the mucosa. These polyps range from 8 millimeter to 2 centimeters. So they were studying the mucosa of the sigmoid and rectum, and there is a transmural. You can see here the entire wall is thickened here up to the 1 to 1.5 centimeter. Scanner microphotograph, we can see here. So this is the mucosa, this is the muscle, this is the serosal aspect and fat. So we can see here heavy deposits, which is almost going transmurally. Here, another photograph, we can see here this large nodular deposit of a lymphoma, which is extending through the muscle, and this is large submucosal deposit, which we can see here. This is projecting as a polypoidal mass here, and these cells are also infiltrating the submucosa and mucosa of the large intestine. This is a section from the urinary bladder. So you can see this is the detrusor, and there is heavy infiltration of the bladder wall by the lymphoma. Bone marrow was examined, and we could see the trilineage hematopoiesis, including this, you can see megakaryocytes. However, there was no lymphomatous deposit from the bone marrow that we examined at postmortem. So this was the extent of the disease. Now coming to the other organs and the complications. So this is the cut surface of kidney. The capsule and the cut surface of the kidney were unremarkable. There were no focal lesions. The glomeruli were essentially normal. There is no increased cellularity. The kidney did not show any deposit, but we can see these proximal convoluted tubules, which there is loss of nuclei. There is vacuolization indicating acute tubular injury. Liver weight 1600 grams, the capsular surface was smooth, cut surface did not reveal any nodularity. This is gallbladder, loop of duodenum, pancreas, which I already described that there was diffuse infiltration in the pancreas by the lymphoma. And spleen weight 320 grams, it was slightly enlarged. The capsular surface was smooth, cut surface did not reveal any focal lesion. Portal vein did not reveal any thrombus. Microscopic section from the liver showed maintained lobular architecture. You can see this portal tracts, hardly any increase in cellularity. There is no lymphometal deposit either in the portal tract or in the sinusoids or in the centrizonal area. Spleen showed mild congestion of the red pulp, and on higher magnification we could see multiple histiocytes here which are engulfing here RBCs and some lymphocytes here indicating hemophagocytic histiocytosis. On a careful examination of the spleen, we also could see these many nucleated cells along with this RBC erythroid precursors, along with megakaryocytes indicating there is extramedullary hematopoiesis in spleen. Then we also look for extramedullary hematopoiesis in other organs. In adrenals, we could appreciate this erythroid precursors. In renal kidney section from the medulla, also you can appreciate this erythroid precursors and some megakaryocytes indicating extramedullary hematopoiesis in these organs. Now coming to lungs, lungs together weight, this is the organ complex comprising of the tracheobronchial tree and bilateral lungs. It weighs 670 grams. The pleura here we can see, especially on the left side, it is slightly dull. And however, on the right side, pleura was shiny. The cut surface here we can see of the lungs, they are subcrepitant to fill and there is fluid or exudating while cutting. The tracheobronchial tree was clean and there was no aspirated material within the major bronchus. Other photograph we can see the branches of the major pulmonary arteries where there was no thrombus. There was no areas of consolidation or nodularity on gross examination of the lungs. Multiple sections examined from the lung showed these alveolar spaces filled with this fluid, so indicating pulmonary edema. So there was a diffuse pulmonary edema. In addition, in some of the respiratory bronchioles, we could see this kind of bacterial colonies. Another photograph where we can see this presence of within the terminal bronchioles with bacterial colonies and some fibrin, and we can see some fungal profile here. On higher magnification, we can see some spore here. So Gram-stain revealed that these were mostly gram-positive bacilli, and PS also highlighted this candidal spores. There was no adjacent reaction, so this indicates that there was aspiration, which must be terminal. Coming to the last organ, that is heart weight 240 grams. The epicardial surface was slightly dull, however, there was no gross lymphometal deposit here. The chambers and the valves, they were normal, there was no vegetation. However, on my microscopic examination of the heart revealed this kind of foci where we can see these multiple lymphoid cells infiltrating within the myocardium, and we can see here these cardiac myocytes are getting destroyed here. And so we could appreciate few foci like this. So in the random section, so another section from heart, we can see an extensive interstitial edema separating these cardiac myocytes. You can see these myocardial fibers are getting destroyed here, and we see this presence of histiocytes and few lymphoid cells in this field. Another photograph, again we can appreciate this extensive edema within the interstitium along with these lymphoid cells. These cardiac myocytes you can appreciate here are completely destroyed, and many we can't appreciate the nucleus and this kind of focus where we can see these lymphocytes, some macrophages, and edema destroying the cardiac myocytes. So there was a definite evidence of a myocarditis in this case. So we tried to work up for a viral myocarditis. However, we could not complete the workup for it. However, we could come across some reports of malignancy-associated myocarditis. So this was one case report, which was a case of acute transient global ventricular dysfunction as a present symptom of an ALK-positive ALCL in a young patient. And although the malignancy or lymphoma-associated myocarditis is quite rare, it has, but only I could come across a few case reports. So one with this ALCL-associated, and one case I came across a DLBCL-associated recurrent pulmonary myocarditis. So the lymphoma or malignancy-associated myocarditis is quite rare, but these are whatever I could come across the literature. They shows extensive interstitial edema, like we saw in this case. Giant cells and eosinophils may or may not be present, and they have described that this myocarditis is possibly due to cytokine surge, which is mostly due to IL-6, and many papers have described that CRP is a good surrogate marker for this IL-6 elevation. And our viral etiology needs exclusion. We are still working up. We'll let you know the result of the viral studies. So final autopsy diagnosis in this 18-year female with ALK-positive anaplastic large cell lymphoma, so involving lymph node, GIT, pancreas, ovaries, skin, skeletal muscle, urinary bladder, and soft tissue. Myocarditis, so I am not sure about the cause yet. I'll keep it open. There is extensive extramedullary hematopoiesis in spleen, adrenal, and kidney. There's evidence of hemophagocytosis, acute tubular injury in kidney, and terminally, patient has aspiration. Thank you, sir.